Mic on? Can anyone hear me? Do I sound good? Okay, good, great. Well, I guess I'm the yang. I'm not sure. Tall, short, that type of thing. Dress well, not so much. So this is my third year presenting at the Interchange, and actually this particular topic, let's see if I can get this right. Front, back, okay, good. Is something that I've been thinking about since the last Interchange. And in the last Interchange, we really talked a lot about counterfeit Avastin and the incident that happened in 2012. And that really got me interested in a very simple research question, which is, what have we learned from counterfeit Avastin? And are we any better prepared for the next counterfeit Avastin now that that's over? Or, well, we'll see if that's over. So as a brief agenda item, we'll be talking about counterfeit Avastin in the US drug supply chain. All of you guys here know what that is, what that incident was, but we're just going to go over some of the brief details. We're going to apply some new methodologies, some new research strategies to address this. One is geospatial analysis, which is the use of geography to kind of figure out where these FDA notices were sent. So we'll talk about that. And then we did some legal and network analysis we'll show you as well. And then, of course, we have some questions and future directions to kind of pose out to you guys. And I hope that will lead to a robust discussion, not just here, but in the future as well. So, oops. There was a picture there, but don't worry. It wasn't material. So all of you know that the US drug supply chain is one of the most controlled supply chains in the world, yet we had a penetration of counterfeit anti-cancer drug, Avastin, in 2012. Contained no active pharmaceutical ingredient. It exposed the fact that we have an international, transnational, whatever you want to call it, trade of criminal trade of counterfeit medicines because it was shipped from many different countries, exposed the vulnerabilities of the gray market to penetration of counterfeits. And what happened is the FDA ended up sending all these notices to all these medical practices, warning them that they may have purchased or administered counterfeit Avastin. And kind of the story ends there, at least from the peer review perspective. If you go to the peer review, not much else in the peer review about this particular incident. Most of the reporting and most of the data we have is actually one from the Wall Street Journal and from Christopher Weaver, who was here last year. So, probably not the most well-researched topic around. So we're going to talk about some top-line data. We're going to talk about GIS, and then we're going to talk about network analysis. For those of you who know me, which may not be all of you, I'm a very multidisciplinary researcher. I like to do things that are in different disciplines and bridge them together to solve problems. And counterfeit medicines is exactly one of those topics you have to do that for. So this is a very visual presentation. So look over there, don't look at me, and I won't take any offense of it, of course. And this was funded by the American Cancer Society, so, thank you, the American Cancer Society, obviously, for funding this. So first, some top-line data. We went to the FDA website, and we wanted to look at all the safety notices they issued. Now, that wasn't easy, as you'd think that it's on a spreadsheet or a database or somewhere. Well, no, it was actually in these PDF warning letters that we had to pull all these addresses out of. For our friends at the FDA, please make this data more accessible in the future. We found 932 FDA safety notices and 791 distinct zip codes. So you're seeing some overlap of the zip codes. And this was between 2012 and 2013. Wave 1 was this first set of notices that went out to about 9 distributors. And then the second wave was for these warning letters associated with this device, medical device king entity. In all, included 48 different states and 2 US territories. California, Texas, Florida, and New York are the ones that had the highest number of notices. And we reviewed just publicly available legal prosecutions. So I'll defer to our experts in the room like Linda on how many more prosecutions were out there, but this is what we found through PACER searches, things like that. And we analyzed that as well. So the first question we had was, what's the difference between those places that got a notice, that's 781, and the estimated 30,000 that didn't get a notice? So we looked at some demographic correlates associated with those that are provided by the US Census Bureau. And we did some correlations to see what demographic correlates were most associated with getting a notice. And they're primarily age-based and ethnic-based, but you got to look at it from a holistic perspective of that's the whole country. So there's a lot of noise, and the correlation is not very high. So it's not very predictive, to say the least. But this is one of the things we wanted to do to kind of try to explore this particular issue. I think visualization is actually better. So on this map here, you won't be able to see, but if you were to stand like where I'm at, you would notice that there's white and black pillboxes. And those are places where an FDA notice was sent. So we basically put all these notices together into one data set, and this is the distribution of FDA notices, warning notices around the country. Based on that, so yeah, there was definitely a slide there. I'm not sure where it is. Let me show you the best I can. Oh, that's weird. Okay, so there was a density analysis, and Matt can back me up on this because he saw this presentation yesterday. And it basically kind of outlines the hot zones here. So you can do some density analysis of how many notices were sent in the highest frequency. So it gives you a better idea of where these notices are being sent. And you can actually, with this map, this is an online map, you can dive into each state and look at, by the zip code level, where these notices are going. Let's hope there's more pictures. So this is also what we call a hotspot analysis, which gives us, it's a statistical model that gives us some level of confidence that these areas are the hardest hit. So you'll see in this picture, it's actually Southern California and New York area. And with this data, then we can look at, well, what's actually happening in those areas? Because if you do this correlation across the whole country, you may be getting some noise from all these other notices that are going on. So what we did in this map was we looked at New York. And this is an area where there's a lot of notices. And I apologize for the colleagues at the other side of the room. I'm over here. But, and we overlaid this data, this map, with healthcare spending, which I believe is Medicare, Medicaid spending. And what you'll see just visually is that it looks like the more healthcare spending, which makes sense because Avastin's expensive, are getting the more notices. So that may be a risk factor associated with potentially being administered or receiving an FDA notice. So you see these areas here. Okay, so this is California. I'm from California. And what we did was we also saw that age was a related demographic correlate. And in this map, we actually don't see that occurring in this area. So if you look at these red spots where there's people of Medicare age, there's a higher concentration of Medicare age eligibility, you don't see a lot of notices. Now that can be explained by a number of different things. People may travel to a clinic, it may not be within their zip code, or potentially, in Palos Verdes, it's a very expensive area, you're maybe getting better care. So there's some things you have to tease out of this data. But what we're trying to do is we're trying to do more dynamic surveillance. So, looking at specific areas and trying to identify, again, demographic correlates that are associated with getting a notice or not. So now we're going to go on to the legal prosecutions, and these are some of the things we looked at publicly available. So we looked at the ones that have been filed, things we've seen through pleadings, things we've seen through the gray literature, et cetera. And of the 18 named defendants we looked at from the 10 cases, it looks like about 10 of those were owner staff. People that are non-physicians, people who are the owners of these distributors, et cetera. We saw about 28% of them were physician owners, so actual MDs, and then some pharmacists. The longest sentence we saw was 24 months, so that's a relatively short time. And I'm sure Linda will correct me, after this is done. But, this is a relatively short time considering the brevity of the crime that was committed. Some of the common themes we see: shipping to multiple states, aware of improper shipment, storage. The narratives are really dirty on these indictments. Some with direct knowledge of adverse events, concealment from staff, and the overarching principle here is profit-driven. Make money. And then other cancer drugs. So we haven't even looked at those. So this is some network analysis, some very descriptive basic network analysis. And what you do is, in network analysis, you try to determine the strength and the associations between relationships. So we looked at all the co-defendants in all these cases. Now, if you'll see, the bigger the circle means that that person had more influence in the network. The thin lines, if you can see them, represent a distributor type of relationship. The thick lines represent a co-defendant relationship. So we're giving more weight to a co-defendant relationship. Now, what this means, other than looking like a bunch of circles on the screen, is that this network here looks like it's in isolation. And Paul Bottomy, who's Aston Martin was on the last page, he looks like one of the central actors. He looks like he has a lot of centrality in the network, meaning that he has a lot of influence in the network. And of course, he's selling to Kincaid, and then New comes up there. And then we see these other groups that are in isolation: Medical Device King, Oze Pharmaceuticals, which we don't know what their network structure looks like because we haven't kind of teased that out in the indictments. So they could be connected to this network, and this network diagram could look a lot different. This is very similar to some of the work computer scientists use to try to identify affiliates and payment processors. So the idea here is if you can identify the network, identify centrality, and you take out the people that have the most influence in the network, then maybe you can have a higher impact. So I'm going to go into some research limitations. I hope I'm OK on time. I don't see Sarah, so she's not telling me to get the hell off the stage. So first, this is a very exploratory study. There's some significant limitations in the data and how we analyze it. So I view this as kind of a concept. We're trying to develop tools and strategies to better assess counterfeit medicine surveillance and also solutions moving forward. Thank you. So again, lack of validated data. We'll talk about that in just a sec. Incomplete information. We're looking at publicly available data using PACER, et cetera. There's a lot of investigations ongoing that shouldn't be public, and we can't assess those as well. Patient awareness. So one of the things we saw is that there's a lot of criminal indictments, but not many patients are coming forward for claims. Maybe because they don't know that they've been injured, or perhaps they're not here anymore, unfortunately. These are cancer patients. So that's potentially a problem. And then the FDA warning letters themselves. So I presented all this data, and the basic fact is that FDA warning letters are extremely poor proxy to determine if someone's been exposed to a counterfeit medicine. There it is. Punchline's right there. But that's the best data we have. So, that's the data we utilize because that's the only data point we can use to kind of assess the geographic distribution. It would be much better if we knew exactly which patients got counterfeit medicine. So this leads me to a general conclusion that this is still the perfect crime. You can buy and administer fake cancer medications to unsuspecting patients who already have a high mortality rate anyway. So, and then maybe they pass away, and you may go undetected because of a lack of robust surveillance. So remaining questions. This is kind of the conclusion slide. 3 years after Avastin, what have we learned? We know that there's a lack of validated data on this particular incident, even though, even in the peer review, what's available from the FDA website, et cetera, there's just a lack of validated data that we can analyze. Based on meetings I've had, I went to the Brookings Institute meeting that FDA co-hosted. There's still this idea that clinicians lack awareness and knowledge about counterfeit medicine, so I don't think we've addressed that very well yet. We don't have any idea of how many patients were impacted, which is the scariest part of this whole story, and that's one of the core questions we're trying to model to try to figure that out, but it's really hard to do when you have this limitation in the data set. And the general question, are we better prepared for the next Avastin? So for the first question, I think it's obvious. You need more robust counterfeit drug surveillance. You need more stakeholders involved in counterfeit drug surveillance. And you need more sharing of data. We should be sharing data, aggregating it up, de-identifying any way you need to. But we need to have more macro-level data publicly available. And we need to start figuring out what the prevalence of counterfeit medicines are in these different countries, including the US. Clinicians remain unaware. Well, we can do a better job of educating physicians through engagement in surveillance. So not telling doctors you're the problem, but actually saying, hey, why don't you engage in surveillance for us, and then you can also educate your consumer. So this is something I've at least presented once to the FDA. They weren't interested in it, but so I'm still going to keep pushing, and hopefully it'll get into the peer review someday. How many patients were impacted? Will track and trace help? When? I don't know. Those are open questions, and I'm willing to explore those in the future. But we should have a better idea of how many patients are impacted if these events occur. And are we better prepared for the next Avastin? I don't think so. I think we're basically, kind of similar to where we're at before. And that's unfortunate because, future cancer patients and patients around the world really depend on us in this room to make a difference. And right now, as a researcher, I don't know what to say. This study actually led me to more questions than it gave me answers. 1 minute, I'm almost done. Financial support, really quickly. I have to do this because they're from my funder. And actually, I'm really grateful to the American Cancer Society. They gave me this grant. They never do this type of multidisciplinary policy stuff, but they were willing to give it to me as a new investigator because I'm a young guy, I guess. So really want to thank the American Cancer Society and the Morris Cancer Center. I won't forget to mention that I had my research associate, did some of the dirty, geocoding on the GIS work. So he took all those addresses and geocoded them in, and then I got to produce the fancy maps. So feel bad for him, but he was funded so he got paid at least minimum wage, very very low. And then Camille Guerrera is a student, JD, with our program in the Masters in Health Law and Policy. Free grad labor is always a good thing if it's good, which is not always good. So she provided a lot of assistance. And then Brian Lang, of course, who couldn't make it today. He wasn't heavily involved in this project, nor was he in the conceptualization of the idea. But it's always great to have a JD, MD, PhD on a paper. And he's a great friend of ours. So very happy to say that he's doing well, and he's a happy guy in kind of semi-retirement. So I think I'm done. I think I effectively got rid of all the time, so none of you guys could ask questions. But if you do have questions, or if Sarah gives me more time, you can visit our website for our Global Health Policy Institute, which we just started. And also, I'm here till 4:45. I got to go back and take care of my 2 kids. So anyway, thank you very much.